Welcome. In the previous session, we have discussed about one cause of iatrogenic retinal injuries, namely that due to laser photocoagulation, and in this session, we will be discussing the other causes of iatrogenic retinal injuries, radiation retinopathy, and toxicity to drugs administered either systemically or intraocularly. Radiation retinopathy is a slowly progressing occlusive retinal vasculopathy which is clinically detectable after a variable period of latency following ionizing radiation to the orbit, ocular adnexa, head or neck when the eye or eyes are included in the field of radiation. The vascular occlusion typically occurs in the zone of the retina exposed to the radiation. So radiation retinopathy occurs following exposure of the retina to ionizing radiation during radiation therapy for either ocular or non-ocular entities and can occur following any type of ionizing radiation, either brachytherapy, external beam radiotherapy or proton beam radiotherapy. Clinically, radiation retinopathy is very similar to diabetic retinopathy and can manifest as non-proliferative or proliferative radiation retinopathy as seen in these two clinical photographs respectively. This clinical photograph also shows the choroidal melanoma for which radiation therapy was initially administered. The posterior pole is most commonly involved in radiation retinopathy, with macular edema being a major cause of visual morbidity in patients with radiation retinopathy. This clinical photograph shows brachytherapy administered to an intraocular tumor with the help of a radioisotope containing plaque attached to the external surface of the sclera with the help of sutures. Latency of onset of radiation retinopathy following administration of radiation therapy can vary between 1 month to 15 years but is most commonly between 6 months to 3 years, and this is very important to remember. Incidence of non-proliferative radiation retinopathy following plaque brachytherapy for choroidal melanoma has been found to be 5% at 1 year and 42% at 5 years following radiation therapy, and that of proliferative radiation retinopathy at 1% at 1 year and 8% at 5 years following radiation therapy. But later, the incidence of OCT-detected macular edema was found to be much higher following plaque radiotherapy and proton beam irradiation of choroidal melanomas. Tumoricidal effect of radiation is based on DNA damage of rapidly replicating cells and generation of reactive oxygen species. The vascular endothelial cells of surrounding healthy tissues are also prone to collateral damage from radiation by the same mechanisms. The endothelial cells are primarily affected in radiation retinopathy with relative sparing of pericytes, and this is in contrast to diabetic retinopathy in which pericytes are primarily affected with relative sparing of endothelial cells. Damage to vascular endothelial cells leads to both vascular leakage and vascular occlusion, and ischemic retina from vascular occlusion produces vascular endothelial growth factor which promotes both neovascularization and further leakage from blood vessels. At detection of radiation retinopathy, patient may be asymptomatic or complain of visual loss. Ophthalmoscopic features of radiation retinopathy are very similar to diabetic retinopathy, and this is very important to remember. Initially, microaneurysms are found, followed by intraretinal hemorrhages and cotton wool spots. Later, macular edema, hard exudates, capillary non-perfusion, and capillary dilatation may be detected. Proliferative retinopathy may develop later, but unlike diabetic retinopathy, traction RD is very rare in radiation retinopathy, as new vessels in radiation retinopathy tend not to traverse anteriorly through the internal limiting membrane to reach the posterior vitreous cortex as happens in diabetic retinopathy. Two features of radiation retinopathy when present may differentiate radiation retinopathy from diabetic retinopathy: mottling of retinal pigment epithelium and unilateral involvement when only one eye has been exposed to radiation. Radiation optic neuropathy occurs due to free radical-induced damage to vascular endothelial and neuroglial cells, and radiation optic neuropathy almost always is associated with radiation retinopathy. Radiation optic neuropathy has a latent period similar to radiation retinopathy. In acute stage of radiation optic neuropathy, optic disc shows hyperemic edema with peripapillary retinal edema, hard exudates, hemorrhage, and cotton wool spots. Later, after several weeks to months, optic atrophy occurs. Other posterior segment effects of radiation therapy include mottling of retinal pigment epithelium, retinal arterial and venous occlusions, choroidal neovascularization, choroidal ischemia, and toxic tumor syndrome, which occurs following radiation therapy for uveal melanoma and is characterized by exudative retinopathy with iris neovascularization and neovascular glaucoma. On fluorescein angiography, retinal capillary occlusion and retinal ischemia, as seen here in this fluorescein angiogram, are the primary findings in radiation retinopathy. Microaneurysms, capillary dilatation, and macular edema with diffuse endofocal leakage may also be detected. Later proliferative retinopathy can be detected on fluorescein angiography in the form of leaking new vessels, and in radiation optic neuropathy, early phases in the fluorescein angiogram show hyperfluorescence of the optic disc and surrounding retina, with leakage from the optic disc in the late phases of the angiogram. OCT can detect macular edema even prior to macular edema becoming clinically apparent, and in the absence of macular edema, thinning of primarily inner retinal layers may be detected. OCTA can detect radiation maculopathy prior to OCT, and it shows reduced vessel density in superficial and deep retinal capillary plexuses as well as in the choroidal vasculature. Several classification schemes for radiation retinopathy have been put forward, with none being considered gold standard. One based on ophthalmoscopy and fluorescein angiography stages macular edema based on extent of retinal ischemia as well as macular edema. Another based on OCT grades the extent and severity of retinal edema, and a third based on ultrawide field fluorescein angiography grades foveal leakage as well as extent of macular ischemia. Factors which increase the risk of radiation retinopathy can be either internal, inherent, or patient-related factors and radiation-related factors. Vascular diseases such as diabetes mellitus, arterial hypertension, and coronary heart disease are known to increase the risk of radiation retinopathy following radiation therapy. Tumor characteristics such as a thicker tumor being treated with plaque brachytherapy, closer proximity of the tumor to macula and optic nerve, younger age of patient at tumor diagnosis, and concurrent chemotherapy also increase the risk of radiation retinopathy. Radiation characteristics which increase the risk of radiation retinopathy include total radiation dose, and it has been found that radiation retinopathy usually does not occur below a total dose of 45 gray, and the incidence of radiation retinopathy increases rapidly when the total administered dose is between 45 gray to 55 gray. For comparison, total dose delivered to the tumor apex by brachytherapy is 80 to 100 gray for choroidal melanoma and 20 to 25 gray for choroidal hemangioma. In comparison to radiation retinopathy, radiation optic neuropathy requires exposure to a higher total dose of radiation to occur. Dose per fraction during external beam radiation therapy also determines the risk of radiation retinopathy, and it has been found that radiation retinopathy usually does not occur with a dose per fraction of less than 1.9 gray, and delivery of doses less than this per fraction is called hyperfractionation, and of course fractionation is not possible with plaque brachytherapy. Cobalt and iridium radioisotopes are no longer used for brachytherapy because of their high energy delivery and significant risk of collateral damage. Instead, ruthenium iodine or palladium radioisotopes are used. In contrast to patients undergoing external beam radiation therapy for extraocular tumors, patients undergoing plaque brachytherapy for ocular tumors are more likely to be followed up long-term by ophthalmologists, and so these patients are more likely to be detected and managed earlier prior to significant visual loss from radiation retinopathy. Differential diagnosis of radiation retinopathy include diabetic retinopathy and its differentials, anemia, leukemia, HIV, and bone marrow transplant retinopathy, which occurs due to high-dose chemotherapy and radiation therapy administered to these patients. Differential diagnosis of radiation optic neuropathy include non-arthritic ischemic optic neuropathy, arthritic ischemic optic neuropathy, optic neuritis, as well as tumor infiltration of optic nerve and papilledema. Management of radiation retinopathy includes sectoral retinal photocoagulation to ischemic areas of retina only after development of neovascularization, intravitreal anti-VEGF for macular edema and retinal neovascularization, but also for optic neuropathy, neovascular glaucoma, and exudative retinal detachment. Intravitreal corticosteroids can also be used as a therapeutic modality For maculopathy and optic neuropathy following radiation and radiation optic neuropathy responds poorly to treatment. Measures to reduce the risk of radiation retinopathy include avoiding error in calculation of radiation dose, application of proper shielding techniques during EBRT, hyperfractionation during EBRT, appropriate positioning of plaque for brachytherapy, regular surveillance to detect development of radiation retinopathy. And this study found that administration of intravitreal bevacizumab at the time of plaque removal and repeating every 4 months for 2 years reduces the risk of radiation maculopathy and improve long-term visual prognosis. This study showed that following plaque radiotherapy for uveal melanoma, loss in 5 or more nasal lines of vision occurred in 1/3 of eyes at 5 years and more than 2/3 of eyes at 10 years following radiation therapy, and the proportions were higher for larger tumors. And as we have mentioned, visual prognosis following radiation optic neuropathy is very poor. Several systemic as well as intraocular medications can induce well-defined patterns of retinal toxicity, and toxicity from systemically administered drugs are typically bilateral. We'll classify drug-induced retinal toxicity based on either the major site of involvement or the major clinical feature. Hydroxychloroquine and chloroquine bind to melanin and accumulate in RPE and uveal tissue and produce a pigmentary maculopathy. Histopathology shows depigmentation of retinal pigment epithelium, accumulation of pigment-laden cells in outer retina, and damage and/or destruction of photoreceptors. Retinal toxicity from hydroxychloroquine or chloroquine develops after several years of therapy. An overall prevalence of retinal toxicity of hydroxychloroquine has been estimated to be 7.5%, but varies with duration and daily dose. Chloroquine causes retinal toxicity more commonly than hydroxychloroquine, and so chloroquine has been supplanted by hydroxychloroquine for therapeutic purposes. Paracentral scotoma, detected by visual field testing, is often the earliest clinical sign of hydroxychloroquine toxicity and can be found before ophthalmoscopic signs become evident. They occur within 10 degrees of fixation, more commonly superior to fixation than inferior to fixation. Later loss of visual acuity occurs when RPE changes affect the center of the fovea. Earliest findings on ophthalmoscopy are pigment mottling and loss of normal reflex in the foveal center, which later becomes surrounded by a pericentral ring of RPE changes centered on the fovea. Within this pericentral ring, pigment mottling occurs in early stage, which is followed by depigmentation as seen here in this clinical photograph, surrounded by a ring of hyperpigmentation, and this is called the classic bull's eye maculopathy, which is very important to remember. The pericentral ring is typically horizontally oval and more prominent inferior to the foveal center than superior to the foveal center. Peripheral pigmentary changes resembling retinitis pigmentosa may also be found and are more common among Asian individuals. Spectral luminosity, fundus autofluorescence, and multifocal ERG can detect early evidence of retinal toxicity due to hydroxychloroquine prior to appearance of ophthalmoscopic signs, and so are used for screening, and this is very important to remember. Fundus autofluorescence, as seen here in this image, initially shows hyperautofluorescence followed by complete hypoautofluorescence in the affected pericentral zone. Spectral luminosity shows attenuation or discontinuity of the ellipsoid zone and thinning of the outer nuclear layer corresponding to the affected zone, as seen here in this OCT image, resulting in the flying saucer sign, which refers to the relatively elevated appearance of retinal layers beneath the fovea, as also seen here in this OCT image. Multifocal ERG, as seen here, shows reduced amplitude and delayed implicit times of waveforms in the affected pericentral zone, and later the amplitude of the central peak may also become decreased. Fluorescent angiography shows transmission hyperfluorescence in the affected pericentral zone. Risk factors of hydroxychloroquine-induced retinal toxicity include duration of therapy, and this toxicity usually occurs after 5 to 7 years of continued therapy. Total cumulative dose, which for hydroxychloroquine is more than 1000 gram, and daily dose, with the recommended safe daily dosage of hydroxychloroquine being less than 5 mg per kilogram per day. Other ocular side effects of hydroxychloroquine and chloroquine include cornea verticillata, which is deposition of pigments on the anterior cornea in a specific pattern. Screening protocol for hydroxychloroquine-induced retinal toxicity is very important and is targeted at detecting toxicity at an early stage prior to onset of visual symptoms. This is very important as well-developed toxicity is not reversible and may even progress despite cessation of therapy. The recommended schedule of screening for hydroxychloroquine-induced retinal toxicity is once at baseline, which can be performed within 1 year of initiation of therapy and annually starting 5 years after initiation of therapy. Patients with certain risk factors such as chronic kidney or liver disease, age-related macular degeneration, and those taking concurrent tamoxifen require more frequent screening examinations and also a reduced upper limit of daily dosage. In the 2016 guideline from AAO, spectral luminosity and visual fields were recommended as screening modalities for hydroxychloroquine-induced retinal toxicity. But in its 2025 revision, AAO now recommends spectral luminosity and fundus autofluorescence as screening modalities for the same, and this is important to remember. If possible, multifocal ERG and visual fields should also be performed, but fundus photography, color vision testing, time luminosity, fluorescent angiography, Amsler's grid, and ERG and EOG are not recommended because of their poor sensitivity to detect early stages of hydroxychloroquine-induced retinal toxicity. Management of hydroxychloroquine retinal toxicity is cessation of hydroxychloroquine therapy, and it has been found that early to moderate cases usually stabilize, but continued progression of retinal toxicity does occur in severe cases and has been documented to continue for over 20 years after cessation of therapy. Clofazimine has also been reported to cause bullseye maculopathy, as seen here in this clinical photograph and in this fluorescent angiogram, and bullseye maculopathy as well as crystalline deposits may also occur following therapy with Ritonavir, as seen here in these clinical photographs and the fluorescent angiograms and fundus autofluorescence. Thioridazine and chlorpromazine are phenothiazines which can cause retinal toxicity, but chlorpromazine is much less toxic to the retina than thioridazine. Here we may note that in contrast to thioridazine, chlorpromazine is much more prone to cause anterior segment pigmentation. Phenothiazines also bind to melanin in retinal pigment epithelium and uvea, but retinal toxicity to phenothiazines is more dependent on daily dose than on cumulative dose. A daily dose of more than 800 mg per day of thioridazine can cause retinal toxicity, and because doses lower than that rarely cause retinal toxicity, screening of patients on phenothiazines is not routinely done. Symptoms of phenothiazine-induced retinal toxicity include blurred vision, dyschromatopsia, with the patient complaining of reddish-brown discoloration of vision, and nyctalopia. 3 stages of phenothiazine-induced retinal toxicity can be described, with the early stage showing mild granular pigment stippling in the posterior pole, intermediate stage showing circumscribed namular zones of chorioretinal atrophy between the posterior pole and the mid-periphery with relative sparing of fovea, and a late stage showing hyperpigmented plaques alternating with atrophic patches along with retinal vessel attenuation and optic atrophy. At this stage, fluorescent angiography shows extensive loss of choriocapillaries as seen here in this fluorescent angiogram. Other ocular side effects of chlorpromazine include pigmentation of eyelid skin, conjunctival pigmentation, corneal endothelial and posterior stromal deposits, pigmentation of anterior lens capsule, oculogyric crisis, miosis, and accommodation palsy. And following cessation of the drug, visual acuity may improve, but often pigmentary changes in the fundus deteriorate further. Dideoxyinosine or didanosine can cause a mid-peripheral pigmentary retinopathy characterized by well-circumscribed zones of chorioretinal atrophy which are arranged circumferentially anterior to vascular arcades. Visual field testing shows constriction of visual fields, but visual acuity is not usually affected. This photograph shows another example of didanosine toxicity, and in this OCT image we find atrophy of outer retinal layers and RPE in the involved zone. Following prolonged therapy, Pentosan polysulfate can cause a pigmentary maculopathy, with clinical examination showing a variety of pigmentary changes in the macula, which include parafoveal pigment deposits as seen here in these two photographs, vitally formed deposits, parafoveal RPE atrophy, and pattern dystrophy-like changes. OCT shows focal nodular hyperreflective RPE excrescences as seen here in this pair of OCT images as well as in this pair of OCT images, and later RPE and outer retinal thinning can be detected on OCT. Fundus autofluorescence shows a characteristic spectral pattern of autofluorescence as seen here in these two images, and also around the optic disc in more severe cases. Deferoxamine can cause pigmentary changes in the macula and periphery, and patients complain of blurred vision and nyctalopia. Ophthalmoscopic features can be varied and include multiple discrete hypopigmented lesions around the fovea as seen here in this clinical photograph and the corresponding fluorescent angiogram, vitally formed like lesions as well as pattern dystrophy like lesions as seen here in this color photograph and the corresponding fluorescent angiogram. In Deferoxamine-induced retinal toxicity, OCT shows hyperreflective deposits in the outer retina and RPE Bruch membrane complex as seen here in this OCT image. MEK inhibitors may cause multifocal serous retinal detachments with at least one focus involving the fovea as seen here in this near-infrared photograph and in this OCT image. Retinal toxicity to MEK inhibitors starts within first few days to weeks after initiation of therapy. Most patients are either asymptomatic or have transient mild blurring of vision which resolves spontaneously. Others require discontinuation of therapy, usually with complete resolution of symptoms. Intake of phosphodiesterase 5 inhibitors, which partially inhibit phosphodiesterase 6, also a component of phototransduction cascade, cause visual symptoms which correlate with serum concentration, and these symptoms are bluish discoloration of vision and increased sensitivity to light. But these changes reverse promptly with decrease in serum levels of the drug. Phosphodiesterase 5 inhibitor intake may also be associated with paracentral outer retinal damage, serous retinal detachment, ischemic optic neuropathy, and branch retinal vein occlusion and ciliretinal artery occlusion. Alkylating agents cisplatin and carmazine can cause three patterns of retinal toxicity. Pigmentary maculopathy as seen here in this fluorescent angiogram, which occurs following intraarterial chemotherapy for malignant glioma, and so is unilateral, occurring ipsilaterally on the side of intraarterial injection of the drug. A syndrome of vasculitis, arterial occlusion, and papillitis, which also occurs following intraarterial chemotherapy, and a constellation of signs including cotton wool spots, intraretinal hemorrhage, hard exudates, and optic neuropathy with disc swelling, which occurs following intravenous chemotherapy in autologous bone marrow transplantation, and so is bilateral. Alkyl nitrites or poppers are inhaled recreational drug which may cause blurring of vision and central scotoma, with OCT showing disruption or discontinuity of ellipsoid zone as seen here in this OCT image, resembling solar retinopathy, which we have discussed in the previous session. Extensive pigmentary retinopathy has also been described with inadvertent intraocular injection of corticosteroid preparations containing preservatives which are not indicated for intraocular injection, overdose of sodium or potassium iodate used to treat goiter, and denileukin detox, which is a chemotherapeutic agent. Among drugs causing retinal vascular damage, we have discussed about alkylating agents. Talc retinopathy occurs in IV drug abusers who crush oral medications which contain talc and inject aqueous solutions of these medications intravenously. Clinical features of talc retinopathy include small white glistening intravascular crystals as seen here in this color photograph, lodged in terminal arteries and distributed characteristically in a perifoveal distribution. Later ischemic maculopathy can develop in some cases, as seen here in this color photograph showing fibrovascular proliferation and vitreous hemorrhage, and in this fluorescent angiogram showing neovascular lesions as well as retinal ischemia. OCT shows hyperreflective punctate lesions in the inner retina as seen here in this OCT image, which correspond to the intravascular crystals. Use of oral contraceptives have been linked to increased risk of central retinal vein occlusion, retinal arterial occlusions and ciliary artery occlusion, as well as acute macular neuroretinopathy, which we have discussed in an earlier session, and these are presumed to be due to hypercoagulability of blood following OCP use. Intraocular administration of more than recommended dose of aminoglycoside antibiotics can result in macular infarction as seen here in this clinical photograph and the corresponding fluorescent angiogram. Intravitreal, intracameral, intraoperative infusion fluid and even subconjunctival injection in eyes with thin sclera can cause macular infarction. These patients complain of severe visual loss with ophthalmoscopy showing retinal ischemia along with arteriolar narrowing, cotton wool spots and intraretinal hemorrhages. Fluorescent angiography shows retinal non-perfusion and OCT shows hyperreflectivity denoting ischemia and edema of inner retinal layers in early stage, followed later by thinning of these layers. The outer retinal layers remain normal in appearance as they are supplied by the choroidal circulation. Later retinal neovascularization, neovascular glaucoma and optic atrophy can develop. Inadvertent intraocular administration of aminoglycosides should be treated immediately by pars plana vitrectomy, followed by maintaining an erect posture of patient's head so as to reduce contact of the drug with the macular retina. Intracameral vancomycin used for endophthalmitis prophylaxis during cataract surgery can cause hemorrhagic occlusive retinal vasculitis, also known as HORV. Typically it develops within a week following surgery, and clinical signs include severe retinal ischemia and infarction, diffuse intraretinal hemorrhages, and exudation along retinal blood vessels as seen here in this clinical photograph. Neovascular glaucoma can occur later and visual outcome of HORV is poor. Brolucizumab is known to cause intraocular inflammation and occlusive retinal vasculitis, which occurred several weeks following injection as seen here in this clinical photograph. Gemcitabine is also known to cause retinal hemorrhages and cotton wool spots as well as uveal effusion. Interferon alpha can cause retinal hemorrhages and cotton wool spots as seen here in these clinical photographs. Vascular occlusions, cystoid macular edema as seen here in these two OCT images, optic disc edema and anterior ischemic optic neuropathy. These are presumed to be due to increased leukocyte adherence to vascular endothelium. Tacrolimus may occasionally cause thrombotic microangiopathy, particularly in solid organ transplant recipients with ocular features including retinal hemorrhages and cotton wool spots, and rarely CRVO and optic neuropathy. Ergot alkaloids in higher than recommended doses can cause retinal vasoconstriction. Procainamide can cause extensive pruning of second-order retinal vessels with retinal infarction, causing severe visual loss. Glucagon-like peptide-1 receptor agonists can cause worsening of diabetic retinopathy, non-arthritic ischemic optic neuropathy, and choroidal neovascularization. Methamphetamine and cocaine may cause ischemic retinopathy, as seen here with cocaine abuse in this clinical photograph, and ischemic choroidopathy. Drug abuse may also be associated with valsalva retinopathy, which we have discussed in the previous session, as well as talc retinopathy and endophthalmitis in IV drug abusers. Cystoid macular edema can occur with topical epinephrine, particularly in aphakic eyes, and resolves following cessation of therapy, but topical epinephrine is no longer used for the treatment of glaucoma. 2 to 5% of patients using latanoprost for glaucoma develop cystoid macular edema as seen here in this fluorescent angiogram and anterior uveitis. This cystoid macular edema resolves following cessation of therapy as seen here in this series of OCT images. This image shows OCT prior to initiating latanoprost. This image shows CME due to latanoprost, and this OCT shows resolution of CME following cessation of latanoprost therapy. Cystoid macular edema from nicotinic acid usually occurs in a small proportion of individuals taking a high dose of nicotinic acid. OCT shows cystoid spaces as seen here in this OCT image, but fluorescent angiography does not show any leakage as shown by this fluorescent angiogram, and this cystoid macular edema resolves with restoration of vision after cessation of therapy with nicotinic acid. Taxanes such as paclitaxel can cause cystoid macular edema as seen here in this OCT image, but fluorescent angiography typically does not show any leakage as shown here by this fluorescent angiogram. Fingolimod can cause cystoid macular edema with OCT showing cysts in the retina and fluorescent angiography showing perifoveal dye leakage as seen here in this fluorescent angiogram. Imatinib can cause cystoid macular edema along with generalized fluid retention in the body, but more common ocular adverse effects of imatinib are periorbital edema and epiphora. Thiazolidinediones have been implicated in causation of diabetic macular edema in eyes with pre-existing diabetic retinopathy. As we have mentioned earlier in this session, Talc and Ritonavir can cause crystalline deposits. More than 10% of patients taking tamoxifen develop retinal toxicity, and the manifestation depends on dosage, as we will discuss. Tamoxifen retinopathy usually occurs following 2 to 3 years of therapy. Histopathological studies indicate that these deposits are actually products of axonal degeneration. Patients taking high-dose tamoxifen have decrease in visual acuity, and ophthalmoscopy in these patients show white intraretinal crystalline deposits, typically in a perifoveal distribution. Cystoid macular edema has also been documented, and rarely pigmentary changes and optic neuropathy can also occur in tamoxifen retinopathy. Patients taking low-dose tamoxifen may not complain of any visual loss or may have only mild decrease in vision, but OCT may show foveal cysts or cavitation resembling macular telangiectasia type 2 in the absence of crystals or cystoid macular edema which occurred in patients taking high-dose tamoxifen. OCT in patients taking high-dose tamoxifen shows hyperreflective punctate lesions in the inner retina and disruption of the outer retinal layers as well as cystoid macular edema. And as we have mentioned, in patients taking low-dose tamoxifen, OCT may show cavitations in the retina. Fluorescent angiography in patients developing cystoid macular edema from tamoxifen therapy shows petaloid pattern of leakage, and fundus autofluorescence shows foveal hyperautofluorescence with macular hypoautofluorescence. Following cessation of therapy, visual function improves with resolution of macular edema, but crystalline deposits can persist. High-dose intake of canthaxanthin over a long period of time causes a crystalline retinopathy, which appears as a ring-shaped area around the fovea with highly refractile punctate crystals in the inner retina, more prominent nasally. Patients are typically asymptomatic, and fluorescent angiography does not show any abnormality. Methoxyfluorine, an anesthetic no longer used, causes a crystalline retinopathy with punctate yellow-white lesions in the posterior pole in a periarterial or intraarterial distribution, as seen here in this clinical photograph. These crystalline deposits occur due to calcium oxalate deposition in both inner retina and retinal pigment epithelium. Following intravitreal triamcinolone injection, large yellow-white steroid crystals may lodge above the premacular bursa and persist for many years. Non-iatrogenic causes of crystalline retinopathy include cystinosis, primary hereditary hyperoxaluria, Sjogren-Larsen syndrome, ethylene glycol poisoning, macular telangiectasia, BAT crystalline dystrophy, calcific drusen, and gyrate atrophy. Overdose of quinine is known to be toxic to retinal nerve fiber layer and ganglion cell layer, and in acute stage, severe loss of vision occurs with bilateral j-red spot with diffuse macular thickening. OCT shows hyperreflectivity of the inner retinal layers, but fluorescent angiography does not show perfusion abnormalities as the toxicity is to the nerve fiber layer. In the chronic stage, vision may recover, but only within a small central island, along with severe arterial attenuation and optic disc pallor, as seen here in this clinical photograph. In this stage, OCT shows thinning of the inner retinal layers with intact outer retinal layers. Sulfur drugs may cause retinal folds along with acute myopia and shallowing of anterior chamber. Retinal folds in this entity typically occurs in younger individuals and does not show leakage on fluorescent angiography. It is presumed to be due to ciliary body and/or choroidal effusion and resolves after discontinuation of therapy. Immune checkpoint inhibitors may cause uveitis due to increased immune response. With immune checkpoint inhibitors, anterior uveitis with or without cystoid macular edema is the most commonly reported form of uveitis, but posterior uveitis, panuveitis, neuroretinitis, and retinal vasculitis can also occur. This photograph shows choroidal detachment due to immune checkpoint inhibitor-induced panuveitis. Other ocular adverse effects include dry eye and myasthenia gravis like ocular myopathies. BRAF inhibitors most commonly cause anti-uveitis, but panuveitis can also occur. Rifabutin can cause uveitis, typically anti-uveitis with hypopyon, but panuveitis and posterior uveitis are also known to occur. Risk of rifabutin-induced uveitis increases with concurrent use of drugs which inhibit metabolism of rifabutin, such as clarithromycin, fluconazole, and protease inhibitors. Cidofovir can cause direct toxicity to ciliary body, manifesting as anti-uveitis with hypotony and vision loss. As we have mentioned earlier in this session, latanoprost can also cause anterior uveitis. Among drugs causing abnormal color perception, phenothiazines cause reddish-brown discoloration, digoxin cause yellowish discoloration, and sildenafil cause bluish discoloration of vision. And several drugs such as isotretinoin, vigabatrin, and crizotinib can cause abnormalities in ERG and or visual fields. Ingestion of colloidal silver over a long period can cause ocular argyrosis with black tears, pigmentation of eyelid skin, caruncle, conjunctiva, and posterior corneal stroma, as seen here in these clinical photographs, and a dark colored choroid due to deposition of brown-black granule in Bruch membrane. OCT does not show any signals coming from the choroid, as seen here in this OCT image, and fluorescent angiography shows a dark choroid pattern, as seen here in this fluorescent angiogram, resembling the fluorescent angiogram in a patient with Stargardt's disease. To recap the salient points, radiation retinopathy is an occlusive vasculopathy which occurs months to years following exposure of the eye to radiation therapy. It clinically resembles diabetic retinopathy with a non-proliferative phase which may progress to proliferative retinopathy. Capillary occlusion of the retina at the site of radiation exposure can be detected on fluorescent angiography. OCT can detect macular edema. Radiation may also cause radiation optic neuropathy. Risk factors which increase the risk of radiation retinopathy include coexisting vascular diseases, concomitant chemotherapy, younger age at diagnosis of tumor, higher total dose of radiation, higher daily fractions of radiation, intraocular tumors near optic disc and macula, and thicker intraocular tumors for patients undergoing plaque brachytherapy. Management of radiation retinopathy include intravitreal anti-VEGF for macular edema and neovascularization, sector photocoagulation to ischemic retina following neovascularization, and intravitreal corticosteroids for macular edema. Visual loss of 5 Snellen lines or more occurred in 33% of patients after 5 years following radiation and in 69% of patients after 10 years following radiation. But radiation optic neuropathy has a very poor prognosis. Hydroxychloroquine binds to melanin and accumulates in RPE and uvea and causes toxicity to RPE and retina, which occurred several years following initiation of therapy with hydroxychloroquine. Ophthalmoscopy initially shows pigment mottling in foveal center, followed by development of a well-defined pericentral ring where initially pigmentary changes occur, followed by depigmentation, which is called bullseye maculopathy. Spectral domain OCT shows thinning of ellipsoid zone in the affected area on either side of the foveal center, called the flying saucer sign. Fundus autofluorescence initially shows hyperautofluorescence, followed by hypoautofluorescence in the affected zone. Multifocal ERG shows depression of waveforms in the affected zone, but later the amplitude of the central peak decreases when visual loss also occurs. Visual field testing detects paracentral scotomas early in the disease process. Screening for hydroxychloroquine retinal toxicity is recommended with spectral domain OCT and fundus autofluorescence and should be done once at baseline and then annually starting 5 years after initiation of therapy. Management involves stopping therapy with hydroxychloroquine. Early and mild cases usually stabilize, but severe cases tend to progress often years after cessation of therapy. Other drugs which affect the RPE and outer retina are phenothiazines, Pentosan, Deferoxamine, Alkylating agents, Clofazimine and Ritonavir, which can cause pigmented retinopathy. Drugs which may cause serous retinal detachments are MEK inhibitors and phosphodiesterase 5 inhibitors. Talc, oral contraceptives, Interferon, Tacrolimus, ergotalkaloids, procainamide and intraocular aminoglycosides can cause retinal vascular occlusion. Intraocular Vancomycin and Brolucizumab can cause occlusive retinal vasculitis. Topical latanoprost and epinephrine and systemic fingolimod and imatinib can cause cystoid macular edema, which shows leakage on fluorescent angiography. Cystoid macular edema can also be induced by nicotinic acid and taxanes, but cystoid macular edema induced by these drugs do not show any leakage on fluorescent angiography. Drugs which can cause crystalline deposits in the retina include tamoxifen, talc, ritonavir, canthaxanthin, methoxyfluorine, and intraocular triamcinolone injection. Drugs which can cause uveitis include immune checkpoint inhibitors, BRAF inhibitors, rifabutin, cidofovir, and latanoprost. Quinine causes toxicity of nerve fiber layer and ganglion cell layer. Sulfur drugs such as acetazolamide, sulfonamide, and topiramate can cause retinal folds, particularly in young patients, in association with acute myopia and shallow anterior chamber. Discoloration of vision occurs with phenothiazines, digoxin, and sildenafil. Thank you for listening.